Good morning, everyone. I'm John from HTN, and welcome to this webinar today, where we are joined by a fantastic panel who are going to share with us some of their projects, and we'll go into their learnings, their approach around those projects, what went well and perhaps what didn't go so well, and their challenges. So we have a very practical webinar for you today. I'm keen to talk about how digital and data can support improvements and support providers against key metrics, and as well to go into the role of digital for independent providers in terms of their services, pathways, clinical teams, and patients. So I have some questions today to ask our panel, but I'm also keen to hear yours in the audience. So if you have any questions, feel free to ask them into the chat, and we'll keep an eye on those as we go, and we have some time towards the end for a planned Q&A as well. And in the chat, feel free to share your comments, your thoughts, or any resources that you'd like to share. Share anything that you like in the chat as well. Just to mention, this session is being recorded and the HTN team will be doing a write-up of the key discussion points, so you can read it back and reflect on the session at a later date or share it with your colleagues if you choose to. So let's start with some introductions. If I could ask our panelists to share their role, remit and organisations and just provide a wider introduction for us. So Penny, welcome to the webinar. And first, can I start with you for a wider introduction, please?
Thank you, John, and thank you for the invite. Just to say, it's great to see a theme around the independent sector. I think that's really welcoming. And as you know, I work across the public and private, but for the sake of this webinar, I will introduce as a medical director for a company called Icon UK, which is an integrated cancer care provider currently operating in Wimbledon in London, with a view to expand growth of radiotherapy services across the UK.
Fantastic. Thank you, Penny. And well timed as well, because I believe today is Cancer Awareness Day as well. So
it is indeed.
Very well timed. Tessa, welcome to the webinar as well. Could we start with a wider introduction for you, please?
Thank you, John. And yeah, to echo Jenny as well, thank you so much for inviting me to be a part of the panel today. I'm really looking forward to a brilliant discussion. So I'm Tessa Mattia, I'm from Radar Healthcare. First as a registered nurse by background, I've worked across clinical care, patient safety, digital transformation. So really looking forward to the conversation and panel today. Thank you.
Fantastic. Thank you, Tessa. And Dan, welcome to the webinar as well. Could we start with a wider introduction, please?
Yeah, hi guys. Thanks for the intros. Yeah, similar to Penny, Dan Bunstone. I'm a GP by trade, clinical director in Cheshire, Merseyside. And I work as a bit of a fractional role, so cover a variety of different things, advisory kind of things, mainly working though for a company called VOR, which is integrating exercise and health and how those two things meet, and also Asterix, where we're delivering different kinds of healthcare using international remote GPs too. Recently just finished a role as urgent care chief medical officer for Hearts Urgent Care down in Hertfordshire.
Fantastic. Excellent. Thank you, Dan. Okay, so let's start with our first question. I'm keen to hear about the projects that you've been working on over the past 12 months. So if you could just take us through some of those in terms of digital at your organisations or independent provider. And as well, could we hear about one project in particular, what went well and why did it go well and what did you learn? So Penny, could I start with you, please, for that one?
Of course, and it will be no surprise to anybody, but similar challenges I face as a clinician in the NHS and similar challenges we tackle in the private sector as well. So I would say that with a wide rollout of AI and AI scribes to support our clinicians, this is one of the projects that we are also rolling out in the independent sector. Because again, we want to see more patients, we want to treat more patients, and we want to make it easy for our clinicians. But I guess you want to hear about a flagship project. I would say the one that we are particularly proud of at Icon is the connectivity with the clinicians, and to be able to actually deliver on our partnerships with the NHS and other providers, we need to have the right digital tools to ensure the connectivity is right and actually the speed of doing the activities in the clinical workflow actually is right. So just to describe what I mean about that, as a global company, we operate obviously across 24 hours, follow the sun model. So for example, a patient who gets a CT scan for radiotherapy planning today in the NHS in the UK, and we are in partnership to treat those patients like we do in Wimbledon, the actual plan of that radiotherapy could be done overnight from Australia and with the right digital tools, and that could be delivered to the UK the first thing in the morning. The impact of that and to be able to do this remotely actually reduces the waiting time for patients to start the radiotherapy from weeks to just a few days. And obviously, I don't need to tell you how significant that is for patients, not just from a patient experience, but from a long-term outcomes from the cancer. And the final one, which we are working at the moment, is a remote supportive oncology application and a digital exercise medicine model, digital nutrition and psycho-oncology survey. So an all-encompassing holistic care model that could actually be done remotely with patients, so they don't need to actually physically come to the unit. That means they can have a self-management tool whilst they're undergoing the standard chemotherapy, radiotherapy that we offer in our centre.
Fantastic. Thank you, Penny. And I'd be keen to go into those projects in more detail over the next hour. To pick up on the exercise and health link, Dan, can I come to you? I can hear about some of your work over the past 12 months and particularly one project and why that's been successful.
Yeah, for sure. Similar to Penny again, a lot of the work we've been doing is around AI and, of course, the ambient scribe things, because, of course, that's going to have a real massive impact, I think, on the future, or certainly some kind of impact. Proactive care, mentioned the 10-year plan. NHS have been talking about this for the last 30 or more years. For me, it's the only way we're going to really, truly get us and NHS out of the cycle that we're in at the moment. We have to try to get to a healthier nation where there's less demand by design. So some of the work we did was focused on hypertension, really identifying actually not new patients with hypertension or the ones we don't know about yet, more focus on the ones we know about and actually trying to treat those patients better, more proactively, reach out and let them know exactly what's going on with their care. We had a really positive impact with that, had a remote team, patients had an app, and they really sort of benefited from it. They loved it too, because it completely changed the relationship from having to try to do battle with my front-end receptionist to try and get an appointment. And actually, we were phoning them to say, listen, things might not be perfect for you at the moment. Here's what we need to do to try to make things better. So there's a real huge impact there too. I think what became really clear is how impactful it was both for the system, because, of course, what we managed to do is we probably saved a number of heart attacks, a number of strokes over a period of time. But of course, that saving isn't in year, it's at years 2, 3 and 4. So we're investing now for the future. But of course, you have to have that element of leap of faith now. You plant the acorns now to harvest oak trees at some point in time.
Fantastic. Thank you, Dan. And Tessa, can I come to you? Keen to hear about some of the projects that you have been working on within the independent provider space.
Thanks, John. Yeah, and brilliant to hear that it is an AI forward space around here as well. That's particularly something that we are focusing on as one of your health tech providers. So Radar Healthcare is a quality management system, thinking risks, incidents, complaints, concerns, audits, workforce compliance, documents, notices, all sorts of things. So as a provider of health technology to lots of different organisations and trusts, we want to make sure that we're staying up to date and even ahead of the market with how we use AI to bring together all of that valuable information that is put into these systems to sort of take out the labour and that laborious exercise of pulling out themes, triangulating the data. But this is done not in isolation, and we don't do it by ourselves. We do it in a true partnership with our customers. So really getting that voice on the ground, voice on the front line to say, this is what we need out of our our platform, how can you build this and support us to be able to do, we need to be able to, do a thematic analysis of all of our incidents. How are we going to do that? And how can we use AI to support that? So that's something that we're really focused on developing and working with our partners and customers to develop together.
Super. Thank you, Tessa. Excellent. So we've had some fantastic examples there. So I'm keen to talk about how digital can support against some of the key metrics that independent providers have, and what are some of those baseline stats, or what some of the evidence that you have seen from those digital solutions and the impact that they've had that can help scale those solutions further, or perhaps might lead somebody on the call to think that that should be more of a priority. So the question is, how is digital supporting independent providers deliver against some of the key metrics that they have? Penny, could you kick us off with that one, please?
Of course. And it's a great question. And of course, one of the key metrics for private providers is the accuracy and the safety of treatment. It's paramount. And for us, radiotherapy is very complex treatment, and we provide this at scale globally. So actually having solutions such as our AI solution incorporated within the radiotherapy treatment to actually check that the dose is the right every day, and the clinician can rely on that data to make sure that the delivery of the dose is where it needs to be. And if there needs to be a change in the dose for more personalized radiotherapy treatment, then that technology can tell us where that change needs to be. I mean, this is absolutely game changing, because we are talking about personalized medicine. We are talking about the 10-year plan talks about genomics. So, we need to tailor our treatments to the needs for individual patients and to improve their outcomes. And I think technology like AI has come a long way to help us do that. So I would say that the biggest for us priority is patient safety, is personalized medicine and accuracy. And AI within the radiotherapy treatment does allow us to do that.
Fantastic. Thank you, Penny. Picking up on AI and technologies linked to accuracy and safety, what Penny's mentioned. Tessa, could I come to you in terms of, have you any examples where your projects have supported safety, quality improvement, and how have you done that?
Yeah, absolutely. And I think sort of the foundation of this is developing a safety system within different technologies, within sort of processes. So a safety system being those structures, processes, behaviors, the culture behind everything that we can work together to identify risks, to prevent harm, learn from incidents, and continuously improve patient safety, patient outcomes. So that's kind of the foundation of it, is establishing a really solid safety system. And then sort of on top of that, like I mentioned before, within a system like Radar Healthcare, we put all of this such valuable information in there, but what are we doing with it? What are we learning from? What are we understanding? What are we doing to improve our care to our patients? So within the platform, we've got dashboards as well. And another key conversation I've had with some of our partners is around how we slice and look at that information, and that becomes standardized within the platform, customized to what each of our partners need, but standardized in a way that, okay, I'm picking this up as a service manager, I'm picking this up as a quality manager, and we're looking at the same set of information, those sort of key metrics, and thinking, okay, what's this telling us? How can we improve on it? Is there something like a clinical audit that we need to do on the back of this data? Or actually, is this becoming a bit of a risk that we need to sort of report as a risk, put some controls in place as well? So it's bringing together all of that valuable information in our safety system, so preventing harm, identifying risks, to really bring it all together.
Thank you, Tessa. Dan, can I come to you? How has data supported improvements, quality, and safety for your organization?
So what we're trying to prove entirely relies on data. So that the proactive care piece has to rely on the fact that we're making an impact, we're making a change, because we're asking for things to do things now. Invest £10 now, I'll give you £100 in 3 years' time. It's that basic principle, effectively, isn't it? Data in the NHS, I think, and I guess anywhere, it's described as the new oil, and of course, I think that's probably pretty true. Now, whether you can rely on that, I don't know. I worked in the CCG as a chair for a number of years, and the data was either correct if it sort of spoke to what you wanted it to, or maybe incorrect if it maybe said something that you didn't want it to hear. So we have to get past that point in time as well. And I think for me, the data is the critical bit. There's lots and lots of data. There'll be lots of people in the room covered in data with their smartwatches or their Fitbits or their MyZones or whatever they're wearing. It's how we then use that data. We put that together to make something meaningful. There is so much out there that's public, accessible, whether you use the NHS kind of data and you can piece all that together and work out actually where problems arise. And actually, I think if you then start to blend that with the harder to access data that the hospitals or primary care or our organizations have, actually you can create something really rich that becomes very bespoke to the individual. I guess lots of the work that Tessa will be doing at Radar, pulling together all of those different resources to work out actually your problem's sitting here, when your assumption is that your problem's somewhere over here. Often the assumption and the reality are two quite different beasts.
Great points, Dan. And Penny, keen to hear from you on your perspective in terms of data and its link to safety.
Oh, I couldn't agree more with Tanya and Tessa. It is time that we actually bring those dots together. And there's so much data in the NHS, fully agree, but what we can do in the private sector as well with wearables, with engaging with our citizens and our patients, how can we bring that together and create those really strong data sets where we can drive, we can drive clinical decision making. We can understand demand of both NHS and independent sector, and we can share capacity. There's so much potential we can do with our data nowadays, but from a patient perspective, again, access to their data, empower them to use them to improve their health. We are talking about from hospital to community, how can we empower our patients to use that data and support them in self-management?
Thanks, Penny. Tessa, so in terms of data, is there an opportunity for AI to support people to process that information like quicker and easier and almost do it for people?
Yeah, absolutely. It's a huge area for exploration and how we use it in an ethical and safe way, of course, as well. But yeah, bringing it together, we're looking at how we sort of put some narrative around all of the data, because yes, you can look at, like what Daniel was saying, you could be overloaded with all of this information, but what's the narrative behind it? Like along the lines of the hand hygiene audits that were completed towards the end of the month tended to have worse scores than those completed, consistently throughout the month. An example like that us as human beings might not necessarily have picked up, because that's not necessarily the audit score. We're seeing that people are passing, so that's a good thing, but it's more of that narrative that goes alongside it, and that's what AI can help us with, because it gives us another way to layer and sort of dig through and inspect and look through all of that data that we're getting.
Definitely. Penny, would you like to come in?
Yeah, I just wanted to add to that again, AI is so powerful. It can look at those complex data sets and patient journey. If I take one of my patients in oncology, it's really, really complex, and they might move from one provider to another with, disparate data sets sitting in different places. But as you know, tumor boards should bring that data together, and AI can help put that together, that has a meaningful, it leads to meaningful conversations about patient care and meaningful outcomes. So it's huge opportunity here. It's so exciting.
Absolutely. And Dan, in terms of using AI or segmenting those data sets, how have you approached that? What has worked well, and is there anything that perhaps hasn't worked well?
I think what becomes interesting is when you look at primary care notes, for example, that is I guess the single source of information for much of a patient's health record. Getting through those, trawling through those in whatever capacity that might be is pretty difficult. So it is often like trying to find the diamond on a coal face. And that's not to say there's lots of useless information. I don't mean that at all. There is lots of information there that is useful for a point in time. But if you're looking for certain things that might lead towards a suspicious diagnosis or something's happened, or even a safeguarding issue, actually being able to trawl through that and getting those subtle bits of pieces of data as a human would take an exorbitant amount of time, and I'd probably miss stuff too, if I'm honest with you. Actually, AI doing that, looking for keywords, looking for themes and trends, looking for attendance rates, that really helps you to get a clearer picture and a context around what you're getting in there to do. So it saves time, it improves accuracy. Yes, there's data risks, and I am not suggesting we go in here with our eyes closed. But my other hypothesis here is if we spend a year or 2 or 3 years making sure we get the GDPR right, actually in that space of time, people will literally die or suffer. The work that Penny's doing, that's exactly the case there, where, you want to be absolutely certain about what's happening and really, really clear about what things are happening. But of course, delaying also has a consequence too. So acting early has a consequence, but stopping and doing nothing also has a consequence that we don't often spot quite so easily.
Absolutely, absolutely. Penny, can we go into a bit of detail into your project around the remote pathway with cancer care and what that means for clinical teams, what it means for patients? Is there an education and communication piece as well that's making a difference, as well as a time difference in sort of seeing people and sooner? Could you take us through that, please?
Of course. I think the communication piece is really important alongside the actual technology and the outcome of it. I mean, we all know that a cancer patient journey is long, okay? No matter which pathway you take or which part of the UK patients are, there are long pathways and they are complex. That's why they're long. So if we can do something in the downstream part of the pathway, not the upstream, which is the diagnostic and the surgical, but actually where the patient is coming for their oncological therapy, then we need to do this. And technology can help. It can help link the right expertise across the globe. It can help with AI make those activities of planning the treatment faster. And it can bring that data together more faster, which means we can do the quality assurance process within minutes rather than within days. And that brings the whole pathway from the patient coming for preparation of radiotherapy to actually receiving it within a matter of a week rather than weeks, which unfortunately it's the case in many areas in the UK. So, but I guess the kind of the way we communicate that is really important, to say that, we have the technology, we can help, and we can support partners if they want to partner with us for better patient outcomes. But as Daniel mentioned, it's really important not to underestimate the risks and the cybersecurity and how we do that. It has to be really well designed. We are lucky as a company because we've got a global expertise over a number of years, so we know how to do this.
Fantastic. Thank you, Penny. Dan, could we hear a bit more about your program where you targeted patients and the app that you've used? How does that work for patients? What are they doing with that?
So yeah, it was great. It was focused on hypertension basically. So what we did was we ran nothing AI based, just protocol based software across the primary care database record. And found our patients that we then risk stratified into categories from 1 to 5, 5 being high risk, 1 being lowest risk. So 5 might be age related, lots of other comorbidities, very high blood pressure. 1 might be simply male, aged over 40, never had blood pressure taken. So of course that sort of full spectrum there. We then ran a remote team, so patients had an app that they would put their details into, and of course they would then very simply type in their blood pressure details or have it Bluetoothed across from their machine, so they would have their own record of their blood pressure across a period of time. They were supported then by our clinical team, who were all remote, who had visions and view of the patient cohort that they were monitoring. Much of the advice they gave was either compliance advice, which was super simple, are you taking your medication, or lifestyle advice, walk more, dash diet, don't eat as much salt, all the helpful things that go with that. We made some real clear impacts. Patients loved it, as I said earlier on, because of course it was us reaching out to them. It was often in their own home and they felt empowered to look after their care. I think the thing that they enjoyed or appreciated the most was, as I said, it's just flipped that entire health relationship from them going to have to go and ask and beg and scream for treatment versus actually we're reaching out to them. Here's what care could look like. Here's what we're trying to prevent rather than what we're trying to treat. The feedback was brilliant. I think the whole fear around people not being able to use digital, of course, exists, but with some support, actually, it's surprising how very quickly you can get people to use digital in a very meaningful way.
Fantastic. Thank you for that, Dan. It's really interesting to hear how data has been used to change the model and go from reactive to proactive, or from having that information and insight. Tessa, do you find that with some of your customers in the independent space? How are they tracking trends or using data to change their care models or make an improvement?
Yeah, and I think a lot of it stems from what we see, particularly from our side, is that collaboration across our independent sector as well. So they're sharing with each other, hey, look, I've tried this. Have you given it a go? Or, what are you doing? We facilitate, well, our independent partners, they facilitate with support from us, a user group, so that we all get together once a month to say, hey, look, what are you doing in the system, or what's working well, what's not working well for you? And a really good example of where we've seen brilliant collaboration across the customers and partners is with LFPSE, Learning from Patient Safety Events, which we know has been around for a wee while now, a couple of years. But, particularly within the independent sector, it was not always clear right from the start whether they needed to do it or didn't need to do it. Is it just for NHS patients? It's not. But they were really able to come together and say, okay, what are you doing? What are we doing? Okay, is our data looking relatively similar against our activity or our patient data? So it's more of that. Yes, it was looking at like the LFPSE Learning from Patient Safety Event dashboards and the NHS portal, but also more of a casual conversation to say, what's it like for you guys? What's it like for us? Can we learn from each other? Is there something that they're doing that's working really well? What questions are you getting asked from your quality teams or director of quality or CQC? Actually, let's make sure we're all on the same page in this. So that's been a really fantastic example of just that collaboration, working together and looking at information from different sources.
Very interesting. Thank you, Tessa. And that's a really interesting question. Like, what is the question that is being asked? So, Penny, could I come to you for this? So, is the digital question in your organization at the moment, is it on cyber? Is it the opportunity of AI, or could it be how it's helping to save costs, or what are some of those questions that you're discussing at the moment?
Well, we are discussing a couple of questions. There's never one problem, is there, that we are trying to solve. Definitely is how do we connect clinicians together? So for us, our clinician network that works with ICON, the global clinical network, is actually what drives patient outcomes. So we need to connect them. So part of my medical director roles is to bring clinical communities together of best practice and link them across the world. That's number one. How do we do that efficiently? How do we do that safely? How do we use that for our tumor board meetings and share information, clinical information safely, so we can make decisions quicker and get the patients to treatment quicker? And the other aspect is, how do we engage with our patient communities? How do we know that we are delivering what we are promising to deliver? That comes through patient-reported outcome and experience measures. And again, digital tech help actually remotely collect that data, so we can be responsive, we can adjust our services, we can do what our patients are telling us we need to improve on. So I would say these are always two questions. How can we make the lives of our clinicians better, but also how do we deliver what our patients need?
Great questions. Is that similar for you, Dan? And how are you tackling some of those questions? For example, how are you making the lives of clinicians better? How are you supporting patients to make their journey better?
Yeah, it's a great question. And that's exactly what the focus is. And certainly for the work we do with Asterix, where our whole hypothesis is around the fact that primary care is really, really busy. What can we do? Because the demand's probably not going to go unless we get the virtuous cycle going that I talked around before, but that's going to take some months, optimistic, years and decades to get to that point in time. So that's a long-term investment piece. What we're doing is really sort of interrogating the data, patient attendances, time of consultation, the amount of blood tests being ordered, that whole thing, that real deep dive and drill down into exactly what's happening. And there's some really fascinating data that comes through. I won't go into patient specifics, of course, but if you look at your top 20% of attenders, actually they will probably consume 80% of your appointments. That will be certainly across primary care, possibly across A&E and urgent care centres too, though I couldn't necessarily specifically comment on that, but I know for primary care. So actually, it's that 80-20 Pareto principle where you deal with your 20% in a better, more proactive way. Actually, you suddenly free up a hell of a lot more time because, of course, you're not dealing with 80% of the time on that 20% of patients. You can then actively focus on other things. Context as well is really important for me too, as I've talked around before. Primary care record is huge. You probably look back for a certain number of consultations, but the reality is you probably wouldn't go back 2 years or 3 years or 4 years unless you're doing a real proper deep dive. And I guess, Tessa, you'll see this in the work you do. Trending out across a number of years brings out some real surprising things that, every November this thing happens that nobody's spotted because it's too infrequent to happen unless you go with a decade's worth of data. So looking at that data, pulling it all together and really working out what's happening is where we're focusing on now, John.
Fantastic. Right, let's just wanted to mention to the audience, if you have any questions, type them into the chat, and if you've got anything you'd like to ask or like us to go into in more detail, that would be great. Tessa, can I come to you for the next question, please? So keen to hear about your priorities at the moment, and could you share a success story with one of your independent providers? Just tell us a bit about what worked well and why.
Yes, absolutely. So we work with lots of different independent partners and customers across the UK, and sort of one that I want to share, which I think has been really, really exciting. With one of our partners, we've been looking at, so yes, our system is a quality management system, like I said, incidents, risks, audits, complaints, concerns, everything sits within that. But how do we layer and overlap that data with things like consultations, visits, activity data, everything that sits kind of outside of the quality management system? Going back to what we've already said as well, we're sort of inundated with all of this data, but how do we pull it all together? And something that we're really proud of is that we're doing we've got a joint submission in the HSJ Independent Providers Awards for Clinical Innovation with Circle Health Group, which we're super duper proud of, because I think it really demonstrates the partnership where one of our partners, our customers, have said to us, hey, look, this is what we really need. We need to pull all of this information together and work, with us, work with their teams and bring it all together, work in partnership for sort of a common goal and a common outcome, goal, objective, and really working together and then say, this is what we need. And we're like, okay, how can we support you with this? So that's something that we're super, super proud of.
Fantastic. Thank you, Tessa. In terms of the shift to proactive care, Dan, so we've got lots of people on the call in NHS roles, and what would you say to them in terms of how they can accelerate some of these projects? So perhaps do them in the short term. What's the case that they could build? What would you recommend in terms of prioritizing those projects and getting them off the ground quicker?
I think what we need to do, and certainly what I did when we were in Warrington, was recognise the reality where we work inside the NHS. We are all stressed from a funding perspective. There's lots and lots of money slushing around, and we have the in-year funding cycles. So for the hypertension project, and to your point, John, it probably didn't profit me to say, listen, we'll treat hypertension now, I need £100,000 and I'll give you £1 million back in 5 years, because of course that wasn't really what the focus was going to be. I think to get proactive care off the ground, you have to do a joint project. So hypertension you would combine with something like COPD, where you can show and you can prove in-year savings by preventing admissions to A&E, all the happy things that go with that, reduce costs of that. And of course, on the back of that, then you bolt on the hypertension project. So they run in parallel, but you've got your in-year savings, so you're saving for now, and of course, you're saving for the future. What you need to do with your system, though, is to negotiate and say, well, OK, let's say we can prove, or at least have a really decent idea that we saved £100,000 this year. Well, I need £50,000 of that back to reinvest into the project, which I'll do, because I will make that again next year and next year. That's effectively the virtuous circle we're describing. It's complex. There's a million reasons why that won't work. But I can tell you, if we're sat here in 10 years' time and I'm 10 years older, the problem will be 10 times or 100 times worse than things are now. We have to do the stuff now. We have to start making those changes now, because we were having those conversations 10 and 15 years ago at the advent of CCGs. And we didn't do enough, or weren't successful enough at what we should have done at that point in time. And of course, this is where we sit here now. Proactive care has to be the focus. We have to enable people to get better. And we haven't even looked at the Marmot principles. I'm just talking about the patients who we know have got problems at the moment, treat them differently, and then reinvest to a successful cycle.
Thanks, Dan. Penny, can I come to you next? There's a government ambition, I think, posted today around 75% of cancer patients to the survival rate to be cured to be 75% in 10 years' time. How can that be possible? But from a digital lens, is there a role that digital can support in achieving that as an aim?
Absolutely. And one of the main things that we need to focus on is prevention, primary and secondary prevention. We know that screening rates for cancer are not where they need to be. And that goes hand in hand with digital literacy, of course, because we know that people from disadvantaged populations, they are less likely to attend for their screening appointments. What effect that has? It increases the risk of cancer being diagnosed at a later stage. And we know that when cancer is diagnosed earlier, it's more likely to be cured with the modalities we have. So there is a lot of work being done, and there is improvement in that space. But I think if we take digital literacy really seriously and try and reduce those health inequalities in access to information, which is peer-reviewed, it's actually the right information, because there's a lot of misinformation out there as well. And as clinicians and leaders, navigate that information with our patients and empower them and encourage them to actually play their bit in prevention, I think that will go a long way in diagnosing cancer earlier.
Fantastic. Thank you, Penny. And Tessa, could I come to you? Any of your independent providers, and could we focus on the cancer pathway? And I'm going to stick with the theme of data and information, which has been throughout this session, which is fantastic. And that says something, doesn't it? Have you any examples where data has led to improvements in the cancer pathway?
Yeah, we work with a few different cancer providers, and sort of one key one that I have observed and that's been shared with our user group and lots of different people, but with Genesis, and they've done some really amazing work on sort of their workforce around their different competencies, particularly in cancer care. There's a lot of variation between the different forms of radiation, and there's lots of specifics between different roles, and being able to look at all of that and look at all of the different requirements for each of the different groups, different therapies, and be able to visualize that and put that into a system like Radar. It's given them such greater visibility and being able to monitor that compliance for all of their staff, and therefore that's making sure that they're operating in a safe way, and therefore that having an impact on patients, making sure that they're receiving care that is safe as well, which has been fantastic. They've put in some amazing work, and that they're really starting to see some of the benefits out the other side of it now.
Fantastic. Thank you, Tessa. Just want to go back to the title of the session, how digital is supporting independent providers. And in 40 minutes, we've heard some fantastic examples, haven't we? And one of the earlier questions was how it's delivering against key metrics. And I think we've covered a lot of those key metrics, and the impact is significant. So that's been fantastic. Keen now to look forward. What are your focuses for the next 12 months, and what perhaps do you want to have achieved in the next 12 months? And if you could take us through any of your aims or focuses going forward, that I think would be really interesting. Dan, could I start with you for that, please?
Yeah, for sure. So staying focused on where the NHS is focused on neighbourhoods, I think I'd like to really get a real clear view on the patients into EMAT. So that sort of really standardized data set again. I know I'm sort of focused there, but actually, unless we know what we're dealing with, unless things are measured, things don't change. And it's great that we have it for areas and roads and sometimes even houses, but I think we can get to what I've called bedroom level data, where it's actually dad or daughter or son or grandma that really needs the attention rather than that household. So I'm really focused on that and getting that really sort of clear view, pulling all the sources together. And I'd like at this point in time next year to be able to say, actually, if we send a nursing team to Mrs. Jones at number 17 High Street, that's the protocol going to go to there. That really, I guess, personalised care, but not the individual person, but sort of on a system level where we're working as a neighbourhood to really wrap care around, really start making that difference.
Fantastic. Thank you, Dan. And Penny, same question to you, please.
I would say very similar answer in a different context, of course, but neighborhood health is going to prevail. We need to, as independent sector, actually play a role in it. And there is huge opportunity that we are working on at the moment to identify with the NHS which are those patients that would benefit, for example, chemotherapy closer to home. How can we offload acute trust from that demand? Because the demand is not going to go away. I think all the speakers talked about this. So how can we help as independent providers without digital tools, without connectivity tools, to treat these patients in the community and select those patients, have communication with those patients, and actually do the public health activities that we are so passionate about, the whole supportive care in oncology, the prevention, the population health, etc. So there's huge opportunity to work together, public and independent, on neighbourhood health.
Fantastic. Thank you, Penny. And Tessa, similar question to you. Over the next 12 months, what are you focusing on?
Yeah, absolutely. Our focus is really to support our customers and partners and really their ambitions and establishing, maintaining, embedding all of their safety systems, making sure that the care that we provide to our patients and clients is safe. We've got a really solid roadmap for the next 12 months ahead, and AI being a really key focus in that, how we're going to, like I said right at the start, keep up and keep ahead of how AI is transforming health technology. We've recently established our product advisory panel as well, so getting sort of some key strategic leaders across health and social care to help us inform those decisions of where, for us, where our best investment is and how that will help our partners. and really continuing that partnership. Like I mentioned, our user group, we're bringing all of our customers together this Friday actually, so it's at the top of my head. But that, like I said, those conversations between different providers, between different types of care, because we go from right through from the health and social care to independent to NHS, so right across the board, and how they can really learn from each other. Yes, always want to talk to someone that's familiar or has a similar service to you, but I think there's learning right across the board, across those different providers, and like the conversations we've had today between primary care, between urgent care, into hospital inpatient care, that whole spectrum, how we learn from each other, collaborate with each other, and I think that will be a real focus going forward.
Absolutely. And I'd like to lead that on to our next question, actually, and my final question. And also, if anybody in the audience has any questions, type them into the chat. So the learnings piece we're particularly keen on that at HTN. So keen to hear if you have one learning from the independent provider space and your digital transformation journey, or as a digital leader, one of those learnings that you would take into the NHS or into your next project or into the future. What is that one learning? And I think that'll be a nice way to close the webinar. So Penny, what is that for you, please?
What a wonderful question. I think one learning from me from the independent sector is that we don't have more staff than the NHS, and we always complain that we don't have staff across sectors, right? And when somebody says, how do you solve a problem? We say we need more staff. But actually, we know from the independent sector, but if we work a bit differently and if we use the right technology, we can be efficient and we can deliver what we need to deliver with fewer staff. And this is reality. We've got the example, we've got the case studies, and Tessa, Daniel have spoken about it. It's actually understanding where the bottleneck is in the patient pathway, in my case, and actually working with your staff to see how can we do this differently and how can this technology enable it. These are the three very important questions. And I think if we take that back to the NHS and we actually ask those questions, we will see that maybe the problem of shortage of staff maybe will become a bit easier.
Great point. Thank you, Penny. And Tessa, can I come to you, almost asking your question back to you? Particularly keen because you have a large NHS trust customer base and independent providers. So what are those learnings that perhaps could be transferred?
Yeah, it's interesting you say that as well, John, because I work with a lot of our different customers from across the sectors, and hearing at the end of the day, we all kind of do have the same problems, like what Penny was saying as well. And yes, we always say we don't want to reinvent the wheel, let's try and learn from each other. But I think there is an area where we can improve on that. And that's having those conversations with each other, being open and honest, being like, well, this didn't work for me, what worked for you? Trying to learn from each other, whether that's looking at big data sets like we've been speaking about today, or a casual conversation within one of the many networks that we've got to really say, this is the problem I'm trying to address, what's the problem we're trying to solve, and how do we know that change will result in an improvement? What have other people done rather than starting from scratch over and over again?
Great points. Thank you, Tessa. And Dan, could I come to you, please?
Yeah, I think the difference I probably spot between the two is the ability to start projects off and get things going. And then when they are going, give them a bit of time to grow and to sprout and to, develop. I think the NHS probably has a bit of fear around spending taxpayers' money, so doesn't want to waste it. Fully endorse that. But actually in the delay, all the bad things happen, stopping and standing still, things are still happening in the background. So I'd suggest an element potentially of getting on and doing things, and sometimes good enough is good enough. It doesn't have to be perfect in the first iteration, and then actually letting things breathe. Achieving success in 6 weeks or 3 months is pretty difficult. Unicorns do exist, though they're rare.
Great point. Thank you, Dan. And that I think that's a nice way to close the webinar as well. We haven't had any questions come in, so I'll look to. Oh, as I say that, a question has come in. So what do you think the biggest barrier is to that sharing, and how do you think we can overcome that in the future about shared learning? How can we overcome that or tackle that as a challenge? Penny, could you take that one for me, please?
Sure. Great question. I think it's down to people. Okay. I think sometimes we are reluctant to share in an open space of what our challenges are. And without recognizing, and actually our challenges in one organization very similar to the others. And if we don't share what works or what doesn't, we cannot improve. So I would say, we should, as leaders, cultivate a space of psychological safe space for us to share. And it could be our weakness in some areas, but that is only done to improve. That's how knowledge is shared, So I would say if we are open and transparent and actually take that as an opportunity to improve, that would be great.
Absolutely. And it's part of why we love what we do at HTN, because say like Dan, your example around the hypertension project, if somebody's on the call about to start that, it would be really valuable for them, I think, to hear that. Tessa, sorry, can I come to you?
Yeah, I just wanted to kind of add to that point as well, and this is what Daniel was saying as well, but it's like that fear of it needing to be perfect before we share it and present our case. Actually presenting what didn't go so well is actually also just as valuable. I think there's a fear around, oh, but actually it didn't quite work, or we didn't really get the results that we wanted to in the time that we wanted to. Like Dan said as well, things take time and things aren't going to be perfect. So don't let that be a fear when you're wanting to share learning.
Absolutely. Thank you. Right, we don't have any questions. We have a comment from Marion who says, as a practice manager, may I say this has been the best meeting I've attended in a long time. So thank you. And yeah, thank you to our panel, Penny, Dan, Tessa, for taking the time out to join us and taking the time to share your learnings, your successes, your challenges, what's worked well and what hasn't. That's really valuable. And I hope everybody in the audience has found that useful. Jenny will be writing up an article to cover and document some of those key points. So that's usually a great read. There will be the recording as well, and we'll make that available. But yes, thank you to the panel. It's been inspiring hearing about some of the successes today as well. I know like you can go into the news and it can be quite negative, but from what we've spoken out today is really positive. So thank you for that. Thank you for everyone for joining too, and we hope to see you on the next webinar we have, which will be next Wednesday. So I'll close the session here. Thanks again to our panel, and have a nice day, everyone. Thanks again.
Thank you. See you soon.
Bye. Thanks. Bye.